Now, when we're thinking about the treatment of sepsis, of course this needs to be individualised, but the place to start is the severe sepsis care pathway, known as the Sepsis 6. And time is of the essence here, so we want to make a note of when we start doing these recordings. And as we go along, we want to make a note of the time, the initial of the person making the assessment, and the result or a comment that we might want to make. So one of the key things here is to get senior personnel involved quickly. So discuss with the senior registrar or the consultant. And then some hospitals have nursing-based critical care outreach teams which can be contacted, which can bring a lot of expertise into the situation. Firstly, we want to give high flow rates of oxygen, 15 litres per minute via a non-rebreathable bag. And in a patient without chronic obstructive airways disease, we want to maintain oxygen saturations of 94% or higher. So maintaining oxygen saturations. Just be careful with patients with known chronic obstructive pulmonary disease, particularly bronchitis presentation. Now we need to know what organism is causing the infection. So before we start antibiotics, we want to take blood cultures so we can identify the cause of the bacteremia before antibiotics, because obviously if we give antibiotics, that'll kill the bacteria and distort the culture. Plus we want to do full blood count, urea and electrolytes, liver function tests, clotting profile, glucose and arterial blood gases if we have access to that facility. And then consider other causes of infection, urine, swabs, sputum. Send those for culture as well as quickly as we can. But then immediately that is done, we want to start on the intravenous antibiotics. Time is of the essence in sepsis. The antibiotic, of course, will vary depending on what we think the cause of the sepsis is. But it has to be intravenous and it has to be quick. So as soon as the blood cultures are out, the antibiotics can go in. Of course, we won't get the results of the blood cultures back for 24-48 hours, so we can modify the antibiotic therapy. But given that the death rate can be increasing in severe sepsis by about 1% every 10 minutes, we can't wait. The antibiotics have to go in. Then next, thinking about fluid resuscitation. If patients are hypotensive, give 20 milligrams per kilogram bolus of sodium chloride or Hartmann's, which is actually quite a lot if you think about it, 20 mils per kilogram of patient body weight. And consider repeating that up to a maximum of 60 mils per kilogram if the patient's hypotensive. Now, if the patient's becoming shocked, shock is reduced perfusion of the body tissues. If there's reduced perfusion of the body tissues, they're going to become hypoxic, and that will generate a change of metabolism from aerobic to anaerobic with the production of lactic acid. So monitoring lactate levels can indicate how the condition is going. If the lactate levels are going up, the shock is getting worse. If the lactate levels are going down, hopefully the shock is resolving. So serum lactate and haemoglobin. And we want to ensure an adequate haemoglobin to carry the oxygen around the body. We don't want an anemic hypoxia. Now these days we don't normally use urinary catheters because of the infection risk, but it's vital that we know that the patient has adequate urine production. So these patients need to be catheterized, regular fluid balance that must be kept up to date, and we're looking for a minimum of 0.5 mils per kilogram per hour of urine output. Hopefully this is all completed within an hour. At 1 hour, Sepsis 6 completed, and we can sign that in our designation. If the patient fails to improve, specialist intervention may be required to assist with early goal-directed therapy. So we might want to treat infected wounds or burns with debridement, for example. So that's the basic sepsis 6. Of course, it needs to be complemented by any other treatment for the condition specifically. But this is what the Surviving Sepsis campaign recommend to improve outcomes in our septic patients. But it needs to be done early. This condition can't wait. Sepsis is a medical emergency and we need to respond as such.